So, afternoon, everyone. We are today at the third class of the curriculum units of advanced topics on intelligent data analysis. Today we have the pleasure of having Dr. Nelson Cuboia. He's a medical doctor with a PhD in clinical and health services research, also invited lecturer here at the Faculty of Medicine. So it's a pleasure to have you here, and thank you very much for your availability to give us this seminar, which I'm not going to read the full title. I leave it to you. So, Nelson, please, you can start with your presentation. Thank you once again.
Okay. All right. Thank you, everyone. Thank you so much for being here. It's a really pleasure to join you today for this seminar on advancing topic on intelligence data analysis. And I want to acknowledge and thank Professor Ruth Almeida and Hernani Gonçalves for the kind invitation. And I want also to thank Professor Luis Azevedo, who unfortunately could not join us today, but he asked me to send his warm greetings to all of you. So Professor Luis Azevedo was also my PhD supervisor and this work that I will talk about today. So we worked together. So he was the mentor and was the one was guiding this work. And then, so I don't know if I can now share my screen. So
yes, please. Yes.
Okay.
I don't know if okay, it's already. Okay.
Okay.
Great.
All right. I hope that you can see my screen and
Yes.
I'm audible.
Yes.
Okay. Thank you so much. So, so in this seminar, the idea is to talk about the Bayesian Geospatial analysis of tuberculosis and the drug-resistant tuberculosis incidence in Mozambique, with the objective to identify hotspots, area, predictors, and sharing pattern with HIV. So, as a brief introduction, I want to ask you all, how many of you have heard about tuberculosis? Have you heard about this disease?
You can raise your hands. Almost all. Here at the room, almost all of them. Those on Zoom, you can also raise your yellow hands.
Okay. Thank you so much. This is a really very ancient disease, but it still kills a lot of people in the world, especially in the lower and the middle income country like Mozambique. So one of the problems that we have on eliminating this disease is about the intervention that has been put in place. We are not driven by the science. We're not driven based on the needs of areas and the people. Most of the intervention was given randomly for people and the geographic area without taking into consideration where there is the most need of this disease. So as a brief introduction, tuberculosis is an airborne disease caused by Mycobacterium tuberculosis. So it's a airborne disease as that the transmission goes to one person to another through droplets, and if someone is infected with these droplets, can either develop active tuberculosis or can go to latent tuberculosis. And if the immunity is still good, can continue living with this way. But if the immunity goes down, they can trigger the active tuberculosis. So those diseases that reduce the immunity of people, so they can really trigger the tuberculosis, like HIV. That's why most African countries with the higher burden of the HIV has also higher burden of tuberculosis. Example, in children where the immunity is very low, so they don't go to that stage of latency. Most of them, they just develop quickly the tuberculosis disease. So if it's not treated, what we know is that 50% of people die with this disease, and 25% they continue transmitting this disease throughout their life, and another 25% they recover from this disease. So far, with this detected, and we have a success rate of treatment around 80%. But when it comes about the drug-resistant tuberculosis, the rates of success, treating successful patient is very low, surrounding 60%. But we have a lot of new cases of drug resistance, which is a really concern in the world. And if someone is not treated with for tuberculosis over the year, it is estimated that it can infect between 10 and 15 people. So it's a disease that really we need to find those people that have disease so that we can treat them. So in order to cap the community transmission. So so my topic will be around this disease, and I will combine now with Bayesian statistics for mapping this disease to understand what are the area of higher risk of this disease, what are the area of lower risk, what are the factors that really affects the incidence of this disease, either the social demographic, healthcare the predictors, or economic predictors, or environments, so that we can see what are the factors, example, in Mozambique that affect the dynamic of this disease. So the following is the topic that I will cover in this presentation, and I will start with this picture. I don't know if someone recognize some people in this picture. Can you raise the hands? Can you speak? Do you recognize these people? Okay. What do they have? All right, great. What do they have in common? Can you guess?
They all have tuberculosis. Did you hear, Nelson? No.
I didn't say.
Just feel free to you can repeat. You can repeat.
They all have tuberculosis?
Yes. All of them, they were victims of tuberculosis. This is the correct answer. Thank you so much. So all these people were victims of tuberculosis, meaning that this disease really is it can infect anyone. Okay. Although that the most people that are affected are those that are in the lower middle income country now, because developed countries have managed to reduce the incidence of tuberculosis. But we still have, even in developing countries, example, in Portugal, there is a focus of this disease around the Porto metropolitan city and Lisbon. So tuberculosis is a global public health problem, mainly in the lower middle income country. And each year, 10.6 million people fall ill and 1.6 million die due to tuberculosis. And Mozambique is among the 14 countries in the world with the highest burden of tuberculosis associated with HIV and multi-drug resistant tuberculosis. So what we know is that this disease is prone to cluster on in specific geographic regions. So these regions may act as area of higher community transmission or reactivation from latent tuberculosis. So knowledge of higher burden area is paramount for effective allocation of resources and targeted intervention. Example for a country as, like Mozambique, where 80% of the government budget to fight against tuberculosis come from international donors. Although the importance of disease mapping in the Mozambique being higher burden card for tuberculosis, little is known about the spatial distribution and determinants of tuberculosis and drug-resistant tuberculosis incidence in our country. So our objective was to analyze the spatial distribution, predictors, and identify hotspot districts for this disease. First was to look at the spatial distribution of drug-sensitive tuberculosis. The second was to look about the spatial distribution and predictor of drug-resistant tuberculosis, because what we thought that is not always all the areas that are higher risk for drug-resistant tuberculosis sensitive to drug that are also resistant, are also higher risk for drug-resistant tuberculosis. And the third study was to look at the tuberculosis in children under 5 years old. This study is very, very important because children, as when they got infected, they develop quickly for active disease. So high higher risk area for tuberculosis in children are considered the area that currently we have active community transmission, because children, when they got the tuberculosis, they develop quickly. Unlike that adults, if we find a higher risk area for tuberculosis in adults, we don't know if in that moment there is a current community transmission, or we have a lot of people that they got tuberculosis a long time ago, and now, because of any other factors, they're now developing active tuberculosis from the latent. Okay. So the first study was to look about on the shared and specific geographic pattern of tuberculosis and HIV incidence in Mozambique. As I said, that HIV is one of the main factors of developing of tuberculosis. In Mozambique, we know that 25% of cases of people with tuberculosis, they have also HIV at individual level. So at this study, we want to look at if this co-occurrence exists at geographical level, so that maybe if we know this area that they are higher risk for tuberculosis and HIV, we can create a program for integrative approach for tuberculosis and HIV in our country. As we know that in most of the literature, it's clear that it's impossible to eliminate tuberculosis in most of African countries without tackling HIV tuberculosis. But we not identify where are those areas that we need to focus our intervention for effective allocations of resources. So for those that they don't know Mozambique, Mozambique is a country in Southwest African region. If you see in this map in your right side, you see we are closer to Madagascar. I think that most of people, they may recognize Madagascar. We have our neighbor, South Africa, in the south. We have in the north, Tanzania. So in terms of the population, in 2024, we were 33 million inhabitants. And administratively, we are divided into province and
Nelson, I'm sorry, we lost your connection with you. Are you hearing us?
154 districts.
Okay. Sorry,
in
Nelson.
In terms of the tuberculosis.
Are you listening, Nelson? Are you listening to us?
Yes, I can hear you. Maybe on my side.
I can hear you. We lost about 15 seconds of connection with you.
Okay. So, but can you see my slides?
Yes. But the image and the sound froze a little bit. 15 seconds about, more or less.
Okay. All right. So I can repeat. I hope that now you can hear me.
Yes. But now it's fine. Thank you.
Okay. Thank you. So I was talking about the Mozambique, which is the country in Southeast African region. If you see in this map in your right, we are closer to Madagascar. It's around 8,000 kilometers from Portugal. So we have our neighbor, South Africa, and we have in the south, and we have a neighbor, Tanzania, and the others, Malawi, Zimbabwe. So in terms of the population, last year we had 33 million inhabitants. And then in terms of the administrative division, we have 11 provinces and 154 districts. So in terms of the incidence of tuberculosis, we have one of the highest incidence of tuberculosis in the world, with 361 cases per 100,000 inhabitants. In terms of the burden of this disease, tuberculosis is the third cause of mortality in Mozambique and affects most of people in the active age, which has impact in the economy of the country. And in 2006, the government of Mozambique has decreed tuberculosis as a national emergency. Regarding to the treatment, to service for treatment and diagnosis of tuberculosis, we have this service in all the country, and the treatment is free of charge. So looking at the methodology of our study, so we use a retrospective ecological study using district as our unit of analysis. So we included all districts of Mozambique. And as a study population, we use new cases of tuberculosis, new case of drug-resistant tuberculosis, and the tuberculosis in children under 5 years old, and HIV diagnosed in Mozambique between 2016 and 2020. In terms of population at risk, we consider the Mozambique population in the year of 2017, which was the last year that we have population national census. So in terms of the predictors, because we wanted to understand what are the factors that contribute to the spatial distribution of the tuberculosis in our country. So we included socio-demographic data, environmental data, health service data, and economic data. So the selection of this data was based on the availability of this information for whole country and the knowledge that we have from the literature that this variable associated with the epidemiology of tuberculosis. So in terms of where we got this data, so the data was sourced from Mozambique Ministry of Health Surveillance System and the Mozambique National Institute of Statistics. Other information we got from open sources like Center for Humanitarian Data website, MapCart, equandir.pt. So in terms of the analysis to estimate the spatial distribution and the determinant of tuberculosis in our country, we use Bayesian hierarchical Poisson regression models. I know that in this course, I think you are having some lectures with Professor Luis on the Bayesian statistics. So this is one of the examples of application of Bayesian statistics to estimate some more values to map the disease. So we computed univariable and multivariable analysis, and the data were analyzed using a software, OpenBags, statistical software, and INLA. And then we ran different models to find what is the best model that fits very well to our data. We use the deviance information criteria to choose the best model. So the model with the lowest deviance information criteria was considered as the best and used to map our data. In terms of the map, so we build the map using this well-known software, QGIS software, and R programming language. So with this analysis, we were able to classify districts in Mozambique regarding the risk of tuberculosis using this exceedant probability. So so we know that the rates when it's equal to 1, it means that we don't have difference, the statistical significant difference. So the district that had probability of exceeding relative risk of 1, more than 95%, were considered as hotspot area, with meaning that the area will have higher risk of tuberculosis. And the district that they had exceeded probability of exceeding their relative risk exceeding 1, between 5 and 90%, were considered as neutral hotspots, meaning that they're not hot, even they're not cold spots, so they were in the middle. And we have cold spot, which are the area with relative risk, probability of relative risk being more than 1, less than 5%, which we consider cold spot, which in theory it means that an area that the tuberculosis itself does not exist. So these are some more mathematical formulas that we use to run our model. This is one of models that we use, which was the best model in all studies, which is a convolutional model. And another in your right side is the model where we combine data for tuberculosis and HIV to see what are the areas that we have overlap in terms of risk and what areas that each disease has its own pattern. So in terms of our results, so the first study was to look at the spatial distribution, determinant of tuberculosis incidence in Mozambique. So we have this CARES code where we published this study, so you can read it. So this study has been published in 2023. So if you want to read more about the results, you just go to this CARES code. And if you want, I can also send you the paper that related to results of this study. So what we found during our study periods were, in terms of the case of tuberculosis that were diagnosed, so in total 512,000 cases, 877 were diagnosed with tuberculosis, almost like the population of Porto City in 5 years in Mozambique. When you look about the notification rates, from 2016 to 2020, we see an increase in the notification rates of tuberculosis in 100,000 inhabitants. So when we look about the spatial distribution of tuberculosis in Mozambique, in the top left, you see this map of Mozambique with a different color. So the colors that you have here, the red, the more the intensity of the color, the higher is the incidence of tuberculosis. As you can see, we have heterogeneity in the distribution of the incidence of tuberculosis. Higher incidence areas that are here in the south and the center region of the country, while in the north region we have really lower incidence of this disease. And in this area, we think that it may be associated because in the south we have South Africa, which is one of the highest burden country of tuberculosis, and most of people in the south of Mozambique, they work in South Africa. So they go to South Africa, and when they got infected, they come back to their country, which is Mozambique, and they infect other people. They start treatment, and most of the time, even before they finish the treatment, they go back to South Africa. So this, we think that the migration pattern can explain this pattern. In the bottom left, you see this is the map of hotspot districts for tuberculosis in Mozambique. In red are hotspot areas, in blue are cold spot areas, and white are the neutral hotspot areas. So we found that among 154 districts, 62 were hotspot districts for tuberculosis. Almost 40 districts in Mozambique are hotspot districts for tuberculosis, and most of these areas are in the south region of the country. When we look about the distribution of hotspots distributed by the province, in my right side in this image, you see that the Gaza province, Chicumbane province, Maputo province, Maputo city, and Sofala are the province with the highest proportion of hotspot districts in our country, meaning that these areas, we need really to look what is going on so that we can really direct intervention to these areas. So when we look at the risk factors associated with incidence of tuberculosis at geographic level, we found that the incidence of tuberculosis increased when the HIV prevalence increased at the district level, and districts with higher average temperature, they had lower incidence of tuberculosis. So for spatial distribution of tuberculosis sensitive to medication, we found that they were really moderated by these two factors, HIV prevalence and average annual temperature. In my left side, so we have created a graph with variation partition coefficient, where we are looking about the contribution of each component of the model on explaining the outcome. So most of the variation of our outcome are explained by coverage, meaning that these social determinants of health are really the ones that are driving the incidence of tuberculosis in our country. So when I look at the second studies on the spatial distribution of tuberculosis, drug-resistant tuberculosis in Mozambique, I can tell you this study as well has been published. So this is a case code for someone who wants to read more about the result and get to have some insight in deep. So you can go to just this case code, and you will find the full text of this study. So what we found that during our study periods, almost 5,000 cases of tuberculosis with drug resistance were diagnosed in our country. And when we look at the notification rate increased from 2016 to 2020. And when we look about at the spatial distribution of this disease across the country, we found higher heterogeneity of this disease more than what we've seen on the tuberculosis sensitive, because the difference between the lower incidence rates and higher incidence rate were almost 45 times. So higher risk areas were all in most of them were in the south of the country, and a few areas in the center, and some in the north region. When I look about the hotspot areas for drug-resistant tuberculosis, we see here are really scant. when we compare to the sensitive tuberculosis. So out of 154 districts in Mozambique, only 26 districts are the ones with the which are the higher the hotspot areas for this disease. The majority of them are really in the south of the country. In my right side, you can see this is the distribution of hotspots for drug-resistant tuberculosis in Mozambique, which the majority of hotspots are in Maputo province, Maputo city, Gaza province, and a few Cabo Delgado, Nampula, Sofala. So meaning that these areas are the ones that really we need to do something in order to curb the occurrence of this disease in the country. And this is a concern because as is the airborne disease, people they move from one state to another. So if we focus on this area, maybe we can curb the transmission to other provinces. So when we look about the factors that are associated with the incidence of tuberculosis at the geographic level, we found that the HIV prevalence was associated with the incidence of tuberculosis. The higher the prevalence of the HIV, the higher is the incidence of tuberculosis. And another thing that we found was the electricity coverage rates, like districts with a higher coverage of electricity, they have higher incidence of tuberculosis. Maybe these areas where we have a higher coverage rate of tuberculosis are those that we have the higher density population, mostly maybe the big cities of our country. So when you look about another factor, we found that the population density, so districts with a higher population density had higher incidence of drug-resistant tuberculosis. Another factor, we saw the proportion of people with bank accounts. So district with the higher number of proportion of people with a bank account, they had lower incidence of drug-resistant tuberculosis. So we use this variable as a proxy of the economic status of the districts. So we go to see about what happened on tuberculosis incidence among children under 5 years old. This study, as I mentioned earlier, it's very interesting because those areas we have higher incidence of tuberculosis in children may give us idea that at the area that currently we have active community transmission of this disease. So during our study period, we found that 29,000 cases of tuberculosis were diagnosed in children below 5 years. And the notification rates in overall, we saw that there is an increase from 2016 to 2020. In terms of the spatial distribution of this disease, we found as well high heterogeneity, and most of higher incidence areas are in the south. This can be explained because this area, as we saw in the first studies, are the area where we have as well the higher incidence of tuberculosis in the general population. And so we know that children, they got tuberculosis from the positive case that can circulate in the community. So it's what we're expecting, that those areas with higher incidence for tuberculosis in general, there may be one that we have higher incidence for tuberculosis in children. But when we look at the hotspot, we just found 39 districts out of 144 that are higher risk of this tuberculosis, which are hotspots. So when we look about the hotspot distribution, most of them are in the south of the country. Maybe these 39 districts are the ones really we need to go there to do something, because currently we may have really community transmission of this disease. When I look at the proportion of hotspot districts based on each province, we saw that most of them are in the south, Gaza province, Chicumbane province, Maputo city, and Sofala are the province with the higher proportion of hotspot districts for tuberculosis in under 5 years old. So going on the predictors of the incidence of tuberculosis in children, one of the factors that we found based on the best model was illiteracy rates. In this study, we consider illiterate people that they cannot read, they cannot write or people older than 15 years that they cannot write and they cannot read. So districts with higher illiteracy rates, they present as well higher incidence of the tuberculosis in children. This is understandable because the level of education, it has really impacts on the disease itself. Maybe this area people, they have lower education and they are not aware on the measure of prevention of this disease. Maybe because in most of this country, people that have lower education mostly associated with the poverty as well. So we found another factor is the density of health care per 100 population. So districts that had higher densities of health care per 100,000 population, they have higher incidence. This can be explained by tourism. Maybe those districts with higher density of the healthcare service, we have more people diagnosing tuberculosis. We have more tools, more hospitals to do that. So we are detecting more cases, but also it may be indicate that it may indirectly indicate these are the urban area because most of the health centers in our country are concentrated in the urban areas. Another factors that we found was the average annual temperature. So area with higher temperature, they have lower incidence of tuberculosis in children. And the last predictor that we found was a percentage of people with a bank account. So district with the higher percentage of people with bank account ownership, they had lower incidence of tuberculosis compared to areas that had lower proportion of people with bank account. This is that understandable because tuberculosis is a disease that is related to the poverty. So these areas that people they have lower income, they have lower economic status, they have really higher risk because maybe they don't have good nutrition, they don't have a condition to go to hospital. So these factors really contribute to the incidence of tuberculosis. So to look at the first study, which was our last study on modeling the joint spatial distribution of tuberculosis and HIV in Mozambique and look at the predictor of tuberculosis. So we found that during our study periods from 2016 to 2020, almost 2 million people were diagnosed with tuberculosis in our country. Like it's almost 4 times the population of Porto cities that we are diagnosed with HIV in our country. And we have this number of 500,012 people that were diagnosed with tuberculosis in our country. When we look about the notification rates, what we see, the notification rate is increasing for tuberculosis from 2016 to 2020, which is this blue line. And when we look about the HIV, the notification rate had 2 behavior from 2016 to 2008. We have an increased trends, but from 2018 to 2020, we have any decreasing trend. And here we look at the hotspot areas for this disease in combination and specific distribution. So we found that this disease really, they have 3 different behaviors. So this EPP, incident posterior probability, which we use to identify hot, neutral, and cold spots, indicates that the area where we have overlap of hotspots district for tuberculosis and HIV is this map in the middle. We found this area are more in the south region of the country, and we have some few regions in the center and a few in the north. So meaning that in this area, maybe the intervention that tackle HIV can have impact on tuberculosis incidence, and even intervention that tackle TB can have impact on HIV incidence. And this area, we think that integrative approach for tuberculosis and HIV can be very beneficial. But when you look in my left side, you see this is a hotspot area for HIV incidents that are not related with the presence of tuberculosis. We see that the areas are, the majority of area of hotspots districts are in the north region. So this open another question. Maybe we have specific factors for HIV incidence in the north that are not the same in the other region of the country. So meaning that these areas for HIV, maybe they have their own determinants specifically, which are not the same with other areas of the country. But when you look in my right side, you find here the hotspot area for tuberculosis. Most of these areas are in the south region of the country. And we have in the north, most are neutral spot, and in the center, neutral spot, and the north, cold spots area. So we have distinct pattern for tuberculosis and HIV in Mozambique, meaning that behind that, maybe the factors are a little bit different for the co-occurrence of the two diseases and the specific incidence of each disease. So in terms of the numbers, so we found that 23% of district Mozambique were hotspot area for HIV incidence, and half of districts were hotspot area for co-occurrence of tuberculosis and HIV in our country, and 41 districts, which correspond to 27%, were just hotspots district for TB, for specific TB incidence. So when we look at the predictor of the spatial distribution of shared HIV and TB incidence, we found two illiteracy rates. So the district with the higher incidence rates represent as well the higher incidence of the co-occurrence of tuberculosis and HIV. And as well, we found the health, the density of healthcare, district with higher density of healthcare as well represent higher incidence of the co-occurrence of tuberculosis and HIV. As you can see, this disease is more than a biomedical issue, is a social, multidisciplinary issue that if you want to tackle really tuberculosis in Mozambique, we have to go beyond the biomedical approach. We need really to work on other areas like education, empowerment of the population, and with other stakeholders in Mozambique in order to eliminate this disease. So I can say a little bit about some limitations so that you can take into account when you interpret this study. So we may have underestimated the number of TB and HIV cases that occurred in Mozambique. We know that some people in this country, even when they got sick, they don't go to hospital. So we used data from healthcare system. So this case, maybe we have missed it, but as we use the data for 5 years, accumulated data for 5 years, we think that this limitation maybe has been overcome. And another thing is the ecological fallacy bias. So the association that we found, the predictor are in the district level, geographic level, are not at the individual level. So we need to interpret careful that these are not specifically for at individual level. And we may have missed some important predictors for this study, but this it's mostly because we have limitation on other predictors. Example, wanted to know in terms of the proportion of migrants from Mozambique to other countries. This data we didn't have. Example, in children, we wanted to know about, example, the coverage of the BCG, or how many people that they got this, how many children they got BCG vaccine in infants, but this information was not available. So maybe future study they can look at this and to give us more insights. But this study has really great strengths. First of all, this is the first nationwide study that addressed the spatial distribution of tuberculosis. Sensitive tuberculosis, drug-resistant tuberculosis, tuberculosis in children, and shared pattern with HIV. And what we found is consistent with other international studies that show that this disease really is not homogeneous, distributed across the country, as we saw in our result that in Mozambique, we have micro epidemics of this disease. There are some areas that, the incidence is very low. It may be like in Europe, but there are some areas that are really of concerns. And we found that this result can help decision makers in Mozambique for drawing TB intervention strategy based on the local context. So far, all the intervention that has been put in place in Mozambique was not based on disease mapping results. We are just the intervention were just rolled out without taking into consideration the burden of each disease for each region. And this result now is been used by the National Program Tuberculosis to roll out new interventions in Mozambique, like active case findings at community levels, and then for planning example distribution of diagnostic means for this disease. So as a conclusion, I want to say that although Mozambique is a higher burden country for tuberculosis and tuberculosis, HIV, and drug-resistant tuberculosis, the spatial distribution of this condition is not homogeneous across the country, as you have seen. Higher risk areas concentrate in the south and the central region of the country, and between 16 and 50% of Mozambique districts are hotspots area for this disease. So the spatial distribution of TB and drug-resistant TB is driven by social determinants of health, as you have seen. So what our recommendation is, like, we need to target intervention in hotspot districts to look at what is going on in those districts. Maybe we can complement with some kind of or qualitative study or some kind of operational study to see what is how the health system is performing in this area, and we can allocate more resources in these areas. And we need to look about the cross-border collaboration, because, as I said, that in the south of the country and where we have a higher number of hotspot districts, we share border with South Africa. And most of people that live in the south of Mozambique, they work in South Africa, in the mines and in the farm. This pattern has been there for more than 100 years after the discovery of the diamond and gold in South Africa. And we need clearly collaboration between HIV and the TB program, and we need to tackle social determinants of health. So as a final remark, we can say that eliminating TB in Mozambique is possible. However, one size does not fit all. So we need to look at the specificity for each province and each district. And this is very good because the Mozambique government used districts as the unit for planning their interventions. So I want to acknowledge all the institutions that helped us to do this study. So thank you for your attention. So if you have questions and comments, so please feel free to ask. Thank you so much.